Good evening, and thank you for all the audience for joining us on the second part of the cardiac amyloidosis workup. Myself, Dr. Abir Bakhsh, heart function and transplant cardiologist from Prince Sultan Cardiac Center. I'm joining this session with Dr. Walid Al-Habib, president of the Saudi Heart Association, heart failure and transplant consultant from King Saud University. We'd like to start the session today with our first speaker.
It's 10 o'clock.
Dr. Hussam Al-Zibtawi. He's a consultant nuclear medicine from King Faisal Specialty Hospital Research Center in Jeddah. He will be discussing role of bone scintigraphy in evaluating of cardiac amyloidosis. So Dr. Hussam, please go ahead. Dr. Hussam, you're mute. You can start.
Thank you. Can you hear me now?
Yes, you're good.
Thank you very much for the honor to the evolutionary role in cardiac amyloidosis. I wish to have happy Ramadan and everybody keep safe, stay safe in this pandemic, and hope that you can enjoy my 15 minutes talk about the bone integrity of cardiac amyloidosis. To start with my presentation, I have to my financial disclosure that there is no financial support from companies, and the opinions expressed in this presentation and the decisions made are not essentially endorsed or shared. The objective of this talk is to remind us and to remind about and just to answer the question why nuclear medicine is involved in diagnosis of cardiac amyloidosis. If you and me agree that nuclear medicine is important for this part, we should address the current available tracers that we use for this diagnosis, how to do tests, and are there any other pipeline or future modalities in the gaps in the diagnosis of these. Definition of amyloidosis is a heterogeneous group of diseases characterized by localized or northern Other types of amyloid can be in heart failure, atrial, or ventricular arrhythmia. The pathogenesis might include the increased production as in light chain amyloidosis or the wild type is usually present in old ages. The light chain amyloidosis of the heart has an annual incidence of 6 to 10 cases in the United States. The number of unfiled cases is increasing over the last decade and now probably accounts for more than 50%. The wild type of the transthyretin, especially those suffering from the FF, the heart failure with the preserved ejection fraction, the mutant type of amyloidosis has an autosomal dimension affecting 4% of Americans. So why nuclear medicine is involved in the diagnosis? Because gold standard biology holds short providing sufficient about expression disease information and for the response of therapy. There are 6% applications of the arrhythmia, perforation of the pericardial and pericardial tamponade, occasional arterial puncture, and which works the cardiac amyloidosis is often delayed as a result of the limited specificity of the other non-invasive. The wide cardiac amyloidosis is particularly diagnosed because of two. First, it hits in old age when confounding comorbidities like similar heart disease frequently coexist and make the clinical picture biased. Also, this type has no specific features. In contrast, the mutant type, the transthyretin, and the chain amyloidosis, which usually are supported with the presence of gene mutated ATTR or so, because of multi-center international study on 800 UMR and in 2016, addressing the 100% specific diagnosis of the frontal cardiac amyloidosis using known traits, especially when they have grade 2 or 3 uptake in the myocardium, and especially for those patients with no abnormal monoclonal proteins. This type of test became proved to be beneficial for early diagnosis and subtyping, especially for the frontal cardiac amyloidosis, even before the evidence of cardiac involvement with other non-invasive disease. So, if we agree that this is important, what are the available Dr. Bontigoli with this table showing the PYP, the HMDP, and the PDP, which are the commercial traces present in the market, showing that the three of them has almost the similar sensitivity. And because the DPD is only present in Europe, most of the countries now rely on the uptake of the PYP. So how to do the test? We can put it right back. There's no specific. However, or the mistakes and artifacts. According to the pictures, you have left 40 while within 5 minutes. The maximum amount of activity is we have to be sure that no air gets into the wire. In 6 hours of operation, just to avoid the disintegration. Option just to check for delivery efficiency, which we have more than 55% between two materials before the action. And because sometimes free technically can concentrate in the thyroid and stomach and confuse the picture with amyloid deposition there. As you can see, this is a good protocol that is online and is actually set by the American the admin for the practice fine. And we adopted, except for certain a little bit modification based on experience. So we start in 1 hour after 20 military injection of the tracer IV. We start with the planar images, taking like a 700 image and anterior, lateral, and left anterior oblique. With the low energy coordination. And after we usually actually in the protocol, the 64/64 metric size is not optimum for the solution, and we usually recommend 256 by 256 in our center for the application. So after we finish the planar images, we start doing the SPECT, and it is either 360 regular SPECT of the chest, or if we have doubts about the uptake in the spine, and we need to have a more elaborate image,
Dr. Hussam, sorry to interrupt you, but there is lots of echo in the voice. Maybe if you stop your video and keep the voice only, because it's not clear voice, please.
To stop the video?
Yeah, actually the video is stopped now. Yeah. So there's lots of echo.
Probably because I took fast. Should I just?
You know, it's the voice interrupted. Lots of interruptions. The voice. Yeah. Okay. The one of the suggestions, Bilal, do you have any option? Any suggestions?
Okay. Is there anything I need to repeat? Is there anything that is not that I have to do that?
Bilal?
The problem is in his internet, doctor. It's lagging.
His internet is lagging? Yeah. Okay. So maybe if you... Yeah.
How about now? Do you hear me now?
We hear your voice, but there's lots of interruptions. It just echoes, goes and comes. Yeah. Maybe if you talk slower, maybe that might help. Inshallah.
Let me try to talk slower, but this might actually expand the time. But I'll try to be shorter down. Okay.
Okay. Thank you.
So we're talking about the SPECT, and SPECT is usually started after the planar images at 1 hour and optional at 3 hours of the injection. And the SPECT is usually the routine chest or the 108 MPI SPECT protocol when there is doubt about the mediastinal uptake. Is it okay now? To go forward for the processing, process images on the one patient of the myocardium with region of interest over the heart, and mirror image region of interest on the contralateral side. And then we calculate the ratio between the mean counts of the two, and the ratio of more than 1.5 is suggestive of cardiac transthyretin amyloidosis. We have to be sure that we should avoid putting the region on the doom of the liver on the contralateral side, because it downgrade the ratio and give us best interpretation. As regards to no uptake in the myocardium, one uptake equal less two uptake equal to the rate, and grade 3 is uptake greater than the rate in the. And this can be clearly identified in the transaxial SPECT images, like in the lower row of the images. And as regards the interpretation and the final diagnosis, it's better to put in the report that the study is either non-suggestive or transthyretin amyloidosis. When the visual score 0, the heart contraction is less than 1, versus the strongly suggested for transthyretin amyloidosis, and visual scoring is 2 or 3, or the ratio is more than 1.5. And we can state that the study is equivocal when the semi-quantitative evaluation is 1, or ratio is between 1 and 1.5. This is how we process and interpret the study. And this is just an example of the SPECT myocardial protocol that differentiates between the cardiac amyloidosis in the above panel and the blood pool images that is not amyloidosis, is negative for the myocardial in the lower one. So are there any pipeline studies or modalities and future modalities that's promising to fill up the gap? And this is my information, or this is where I got the information, source of information about other imaging modalities that can help in the cardiac amyloidosis, especially by Bukhari, that's published in 2014. He pointed into 3 SPECT materials that can help in the assessment of cardiac amyloidosis. The first one is the iodine 123 MIBG. And the theory about that, the cardiac amyloidosis results in potential risk of arrhythmias. And this may be due to the amyloid infiltration of the heart nerve conduction system. And we know that the MIBG is a norepinephrine analog, and it can be used for scanning the conduction system of the heart. And one of the studies did prove that the mutant lower heart issue compared to the other subtypes. And the importance of that early detection of cardiac denervation in those cases, awake transplantation is independent because hepatic denervation occurs early in the disease. And this is one of the examples where two patients who had cardiac amyloidosis by the bone scan. The left side has a normal MIB uptake with both myocardial to the spinal ratio. And this patient had both the normal versus the one who had low MG myocardial to the spinal ratio. The second research called I1 to PSAP. stands for serum amyloid P component. And to just repeat that the serum amyloid P component are constituent of all the amyloid subtypes. So we are amyloid. And iodine however, it has one shortcomings. Is that the permeability of the tracer is weak, and this study is not good for assessment of cardiac amyloidosis. However, for the systemic amyloidosis, if we compare the normal study on the either one has significant cardiac for amyloid deposition, and the right hand one has amyloid deposition difference. So the third SPECT study, protein, it's a magnesium labeled study, and protein is and the protein usually has the normal in the liver, kidney, spleen, to the renal bladder. However, if we see any extra actually like this D picture, or in the muscle, this is diagnostic for amyloid deposition. The PET study. We know the difference between the SPECT and PET is that the PET uses the gamma camera, the little gamma camera, where the PET uses traces that's coming up to the cyclotron with higher activity and density, and we can also apply the SUV quantification. So PET imagers, PET tracers are direct imaging of the amyloid. Use for Alzheimer's disease. So we can amyloid deposition too, and PET tracers, especially the carbon 11 Pittsburgh D, we call it carbon 11, which has a shorter half-life, and it needs to be close to the cyclotron. And the F18 flow the back with the F18 2 hours is available even in centers away 2 hours or away. So both components are for quantification burden, identification of early cardiac before during cardiac structure. In a study of 10 patients with amyloidosis, biopsy proven the carbon was seen in patients, so 100% sensitivity. Actually, one features 5 minutes after the injection of the compound. And this is just an example of the F18 flow with cardiac activity, and this is diagnostic for cardiac amyloidosis. So, how is the percentage of different nuclear studies for diagnosis of amyloidosis? We can see that there's increased uprise from 1980 up to now for the bone tracers in the brown line, and also the PET is increasing rapidly because it is and kidney for the MIBG as well as the SAP. So in summary, cardiac amyloidosis has multiple subtypes and is underdiagnosed up to now, and it may be upward. We need the disciplinary team to be involved in the management. The technetium PYT imaging that's available right now is important for investing, especially for the transplant in cardiac amyloidosis. Very overvalued, especially for active grading and exclusion of the residual blood flow activity. So, other types of amyloids, qualitative and quantitative. And lastly, I would say thank you for listening. I hope that I can give you some about the PYT and the other tracers. Thank you.
طيب بقول لك يعني هو اصلا up to 1000 بياخد up to 1000.
Okay.
So, am I on time?
So thank you, Dr. Hussam, for your lecture. And I would like the audience to write their questions addressed to Hussam in the Q&A panel, and we will go over them after the second presentation. So without further ado, I would like to introduce my dear colleague, Dr. Sulaiman Kharabsha. He's a consultant in invasive cardiology, director of the CCU and telemetry unit at King Faisal Specialty Hospital, Riyadh. He's also an adjunct associate professor of medicine at Faisal University. Dr. Sulaiman Kharabsha will be discussing management options of cardiac amyloidosis. So please, Dr. Kharabsha, you may start.
Thank you very much. I hope, let's just make sure that the sound is good. Please give me feedback. How are you guys? Do you hear me well?
Yeah, your voice is very
clear, not cutting. Okay, very good, very good. I will go. Please let me know if there is any problems. Anyway, so we'll go to the sort of, I know that you've been hearing for now, this is the second day about cardiac amyloidosis. We will not do any repetition. We'll go to the therapy and let's talk about the pathophysiology of the symptoms or what creates the symptoms in cardiac amyloidosis. As you see here, there's infiltration of the myocardium with those myofibrils, with the amyloid fibrils, which will cause increased thickness, increase the passive stiffness, and impair the active relaxation. So the problem is with the filling. So you have a small cavity, which is basically poorly distensible. You cannot distend it that much. Even if you give a longer filling time, let's say, people who think like, you know, it is like, let's say, mitral stenosis, where you slow the heart rate too much, you will, in the contrary, if anything, you will develop maybe diastolic regurgitation, if anything. So it's a small cavity, cannot be distended or relaxed actively. So that's one of the main issue, and it's very stiff. And hence the therapy will rely on that. As you see here, we talk about different therapeutics. We'll go over them one by one. The salt restriction is a universal thing for heart failure. As you know, all patients should be salt restricted. And the diuretics should be used basically very judiciously, let's say, because you want to treat the volume overload, but those patients, they have a stiff ventricle, they are very much preload dependent. If you over diurese them, they develop hypotension. As a matter of fact, now treating, you know, one of those patients in my CCU now, again, the blood pressure is very marginal. You have to be very careful, you know, giving the diuretics because they don't tolerate a lot of, hypertensive or a lot of diuresis and a lot of the blood pressure therapies, which we will talk about in a second. So the diuretics are used, as I mentioned, for the volume overload. We're talking about the Lasix or the furosemide. Problem with the furosemide, you know, it has a very much erratic absorption. Some people absorb 20%, the others absorb around 80%. And with the involvement of the GI tract, like I'm sure Dr. Baha and Dania mentioned, and there is maybe malabsorption, some of them really, especially with the congestion, they don't absorb it very well. So sometimes we have to get them something that's better absorbed, like torsemide. Mineralocorticoid antagonist like spironolactone is given, especially to counteract to aid with the diuresis and counteract the hypokalemia, of course. But as I mentioned, be careful with the over diuresis because they are very much preload dependent. The ACE-ARB, most of those patients are very much intolerant to those drugs, especially with the use of diuretics. Their blood pressure is usually very borderline. And toward sort of once the disease advances or toward the end of the sort of the disease, we end up stopping all of these medications, unfortunately. Calcium channel blocker is a contraindicated. Remember, Dr. Hussam was explaining that we are imaging them with bone tracers. This is the interesting thing, that those myofibrils, they have a very high affinity for the calcium. So calcium channel blockers tend to go and accumulate in the heart, especially the non-dihydropyridines, and they can cause hyperphysiological response, we call it. And they develop toxicity, basically high-grade AV block, even with therapeutic doses. So that's why calcium channel blockers are contraindicated in those people. Digoxin is, as I mentioned, is a relative contraindication. Again, it binds the fibrils with very high affinity. They say around 97% of the dose is accumulated in the heart within half an hour. So we should be, when we use it, we should use it very carefully. Now go to the beta blockers. This is very important because, as I mentioned earlier, that we have a small, stiff cavity. So the cardiac output is a function of the heart rate, remember, plus the stroke volume. Stroke volume is very limited, so you really have to maintain your heart rate to maintain your cardiac output. I always give an example. If you have, let's say, a heart rate of 80, you know, with a small cavity, 40, let's say, ml, if you multiply them, and then, you know, if you cut the heart rate to 60, you will reduce the cardiac output significantly if you just do that math. And those patients really become very symptomatic. So using beta blockers, some even they say it's contraindicated, but we use it very carefully like digoxin. So the whole mark of this disease, as you see, is very much intolerance to those heart failure medications, which we use routinely. Anticoagulation, we'll talk about it in more detail. As you see, the anticoagulation, especially in patients with sinus rhythm, is an issue here because they develop what we call it electromechanical dissociation of the atria related to infiltration of the atrial wall. We don't have a recommendation to anticoagulate everybody, but if the patient have especially any signs or symptoms of embolization, they should be anticoagulated when they are in sinus rhythm. Number two, when the patient develops atrial fibrillation, we don't calculate CHA2DS2-VASc score in patients with amyloidosis. We just anticoagulate them right away. So this is something we should remember. As you see, we go over all these medications, and here I just want to mention that even some we use midodrine to maintain the blood pressure because of the borderline or the low blood pressure in those patients, which relates to, as I mentioned, to the use of the drugs, the diuresis, and the autonomic dysfunction in those patients, unfortunately. Now, the treatment for, let's talk about AL amyloidosis. AL amyloidosis is not usually our field. We don't spend a lot of time talking about it. Once we diagnose the patient, we send them to hematology. It's a plasma cell dyscrasia. It's secretions of, you know, this light chain, usually lambda more than the kappa. And they're treated with chemotherapy to kill those plasma cells, as you see here, cyclophosphamide, dexamethasone, and bortezomib. Those patients usually are very sick, they're ill, and they're usually very much intolerant to the usual doses of chemotherapy. So they usually start with the low dose chemotherapy, gentle, and they look at the hematological response. And their prognosis eventually is dictated by that response. If there is poor or no response, their prognosis is very poor. And if you look also at the prognosis, it's also the mode of death is usually heart failure and sudden cardiac death, unfortunately. So the orthotopic, let's talk about the liver transplantation. This is, as if you think this is for the mutant or what we call it the hereditary type, because the wild type, first, they're very elderly. Usually they're elderly men. Second, the liver is normal. There's no problem. And, you know, the transthyretin is excreted normally, but it just misfolds, tends to misfold more. So really doing liver transplant for a wild type does not make any sense, you know, pathophysiologically. But it's usually reserved for the mutant type. But the problem here, as you see here, where I'm pointing, that you do slow the progression, but you never halt it. There is apparently enough deposit in the heart that will cause continuous deterioration of the cardiac function. And that's why it was never really, or it never became sort of a widespread use or a cornerstone therapy for this disease, unfortunately. Using, again, the heart transplantation, when we talk about heart transplantation, wild type, just by virtue of the age, elderly with a lot of comorbidities, you can just exclude them. Rarely we use that. Again, to use it for the mutant type, again, they have to have also good functional capacity. Remember, the mutant type also causes polyneuropathy. So if the patient's already crippled or having severe neuropathy, then he's not usually, those are excluded excluded from the heart transplantation. Now doing an orthotopic liver and heart transplantation, for those people who deal with that or working in a center where you do, you know how difficult is it to get two organs anyways. But it's reserved for young people, with, a disease, they feel that you can sort of prolong their survival with it. So it's done, but not really widely. So the organ transplantation in amyloidosis, you will see that it's not common. We really don't do it commonly. So even because the problem, even when we send them for liver transplantation, let's say the hereditary type, they are put on the back burner because their liver is functioning normal. They don't have, liver dysfunction. They don't have ascites. They don't have, let's say, from the liver disease, hepatic encephalopathy. But they do have ascites, of course, from heart failure. Now, we talked about these sort of supportive therapies, and we talked about the transplantation as a mean of sort of cure to the disease. But what about the disease-modifying therapies? Do we have a therapy that will modify the disease, not only treat the symptoms? We have we have different stations where we can work on. One is on the liver, try to silence the ATTR gene, where we're using this patisiran. Now it's been used for the familial, it's approved actually for the familial amyloid polyneuropathy. It's, it's a messenger RNA to silence that gene, stopping the production of the transthyretin, or that hereditary, the transthyretin, whether it's hereditary or wild type. The second station is binding that transthyretin and stabilizing it, preventing it from misfolding and forming these monomers and later oligomers and the amyloid fibrils. And the last station is to degrade these fibrils. And as you see here, there is this anti-serum amyloid protein, which we'll talk about it in a second. And the second is the combination of doxycycline and the TUDCA, or the turo-orthodeoxycholic acid. We'll talk about these in detail. Let's talk about the degradation and the doxycycline TUDCA combination. I just want to show you here, look at this, the phase 2 trial. The phase 2 trial, 12 months, dropout was 86%, caused mainly by treatment failure, and 14% by side effects. So you can imagine when you have a dropout that high, that this is not really a drug to talk about. There is a phase 3 trial still ongoing, so we don't have a lot of data on that to support it. It's been used more in the FAP, or the familial amyloid polyneuropathy. We talked about the patisiran, or what we call it, the RNA silencing therapy. As I mentioned, there is one drug called patisiran. It's already approved by the FDA for the familial amyloid polyneuropathy, and hopefully there is studies going on ongoing for the amyloid cardiomyopathy. So likely we will hear about it more and more. Now the anti-serum amyloid protein, the idea is this for the antibody, these are a monoclonal antibody to go attach. And when the antibody attaches to the antigen, it triggers a macrophage-mediated clearance. And they tried that, as you see here, in mice. And there was a very potent giant cell reaction that efficiently removed massive visceral amyloidosis. So this is also a very promising to clear whatever deposited in the heart. Remember, the problem, as I mentioned, you do liver transplant, but there's a lot of amyloid in the heart, so you have to clear that. Otherwise, the disease progresses. What about the stabilizer? We want something to stabilize that transthyretin and preventing it from misfolding. So the diflunisal is a non-steroidal anti-inflammatory drug. Really, just knowing that in heart failure, those drugs are contraindicated. So I really don't want to spend a lot of time. There is really 3 small studies, one Japanese, they all less than 20 patients by the one. One is by Dr. Gilmore in England, and this is Dr. Mazen Hanan in Cleveland Clinic. And look at the study, 23 patients over almost 10 years in Cleveland, followed up median 15 months. And then they were following them. Actually, I talked with Dr. Hanna personally, and he said we really followed them very closely because of the fear of renal impairment. There was no significant, bleeding events or problem, but 3 out of the 23, 13% withdrew treatment due to side effect, as you see here. No patient died, and or were hospitalized for heart failure. This is sort of the study, very observational, retrospective, longitudinal study, nothing major about this drug. But as I mentioned, the other drugs, again, the same. The drop rates were high related to the side effect. It's a non-steroidal. If you want to give it, it's a 250 milligrams BID. You have to watch the patients very carefully because of the fluid overload, because of the side effects from non-steroidal. Green tea, I just want to tell you about it so that you know, it's just for the sake of completion. Green tea was studied in Germany. Again, a very weak study. I just want you to know so that you don't say Dr. Kharabshi was not fair, he did not mention it. But look at this, 19 patients followed for 12 months. They did echo, MRI, and some blood tests. And as you see, all patients were asked to drink around a 1.5 to 2 liters. Imagine your patient on fluid restriction, so you don't want him to drink that much. And this is especially brewed 3 to 5 minutes at 100 degrees. Now they're making this concentrate, basically green tea extract, as they call it, GTE, 300 milligram in a capsule to avoid the volume. And 5 patients were not followed up out of the 19, imagine, or the 20. 2 died. 2 discontinued the therapy, 1 was transplanted the heart, so you can tell. They looked at this, LV mass by the MRI. There was significant reduction in the wall. By the echo, there was reduction, but it was not significant. The mitral annular systolic velocity improved significantly, and most importantly, the cholesterol improved. So it's a good thing for your cholesterol if you want to try. What about other drugs? I mean, until now, we really don't have a drug that really works for a drug without, let's say, a safe drug, a drug without a lot of side effects that works for those patients. And until, the tafamidis was introduced. The tafamidis was used again for the FAP, the familial amyloid polyneuropathy, with a dose of 20 milligram. And it was tested in phase 2 trial in the cardiac amyloidosis, and it was found to be very safe. So the ATTRACT study was conducted in 2000, actually it was published in 2017. As you see, the tafamidis is a small molecule that binds the thyroxine binding site. So it binds to the same site where thyroxine bind on the transthyretin. Remember, transthyretin is a transport for the thyroxine and some other hormones. So it binds the same site and stabilizes the molecule with a very high affinity. The trial, as you said, was conducted for almost 30 months, and they tested doses 80, 20, and placebo. And patients, as you see here, age between 18 and 90, and documented ATTR with biopsy. And those patients, they did have heart failure, and they did have high NT-proBNP. So these are confirmed cases. The primary endpoint was the mortality, as you see, the combination of mortality and cardiovascular-related hospitalization. And the secondary endpoint is the 6-minute walking test and the quality of life, the Kansas questionnaire. You see the numbers here, 441 patients, then the randomized were 264 and 177, 52 and 54 dropped in either group. So exactly the placebo and the tafamidis is the same. And then they show you the number of patients who died during the study. Looking at the baseline characteristic, the age is around 75 because the majority were a wild type, as you see, 75. 75 is a disease of elderly men, as you see, 91% were men. And the majority were white, and if you see them also 2/3 were basically NYHA class 2 and 1/3 NYHA class 3. So looking at the primary endpoint, as you see, there was around 30% basically reduction in the primary endpoint of the mortality and the cardiovascular hospitalization with a very significant p-value there. When you looked at the mortality, also again, there were 30 to 33%, whether you count heart transplantation as an endpoint or not, or the mechanical support. So it's around 30%. Interestingly here, I want to show you that, look at this, the curves start separating at around 18 months because this is a chronic disease. You don't give a drug and the patient improves next day. So this is basically you're blocking the further deposit. Look at this, the benefits start showing up and the curves basically separating at around 1.5 years, which goes with the disease pathophysiology. As you see here, there was a reduction of cardiovascular related hospitalization, again by 33% with a highly significant p-value. And when you look at this basically for a spot about whether the TTR, whether it was a mutant or wild type, both were to the right side of the curve. Whether it's cardiovascular related hospitalization or the survival, both were on the right side. Whether the NYHA class 2 or 3, again, for the survival, both did improve. For the hospitalization, the class 3, though they're a smaller number, they had higher hospitalization. But this is, if you think about it, this is those patients with advanced disease. And for the therapy, it took around 18 months, which is over almost or half of the study period before you started seeing effect. But look at this, the survival, everybody derived survival benefit. This is important because I don't want somebody to ask me, oh, the class 3 did not derive. They did derive. When you look at the cumulative endpoint, both derived in class 2 or 3, and they derived survival benefits. So we should not ignore that. And the doses, as you see, 80, 20. Now, by the way, just to make sure, now we have only the cardiac dose is the American manufacturer dose, going to be 62 milligrams, no more 20 and 80. But the 80 currently is, after, with the sub-analysis, they found definitely 80 was superior than 20. And the 80 is the cardiac dose. The 20, they use it for the FAB or the familial amyloid polyneuropathy. And now the new manufactured dose, actually, we don't have 20 or 80, it's 60 for everybody, but this is for the cardiac dosage. Now, what about the 6-minute walk test? As you see, the decline of the function was significantly better with tafamidis, and the quality of life of this maintained very well compared with the placebo. So really, even those secondary endpoints show significant, with a very significant p-value pre-specified. Now looking at some echo parameters, everything was in the right direction. I don't want to go into the details of that. Really, the primary and secondary endpoints were the more important. What about the treatment emergent adverse events? Whether it's all, whether it's the most serious, whether it's severe, definitely tafamidis was less than placebo. This is very, very important. So the summary was that the drug was well tolerated. It has a great safety profile, almost comparable to placebo. And if there is a treatment emergent, as they call it, adverse event, it was only mild or moderate. And permanent discontinuation was basically even as or less than placebo. And the tafamidis significantly reduced all-cause mortality and cardiovascular-related hospitalization. It did improve, as you see here, the functional capacity, and it did improve a quality of life at basically no cost. I mean, the safety was really a very strong point here, which is comparable to placebo. Let's talk about now other therapies which might happen during the disease course. Now, permanent pacemaker, as you see, the mutant type, remember the mutant type, I'm sure Dr. Bahau, Dr. Daniel mentioned that, there is different types. The valine methionine at the site 30, which is mostly the neurological mutation, but some of it, if it happened later in life, they present with cardiac or a mixed disease. They will end up, 1/4 of them will need pacemaker during their disease time. The cardiac mutation, which is very common in African American, this is the common in African American men, the valine isoleucine at the position 122, around 1/3 of them will require pacemaker, and the wild type, almost 43% will require pacemaker. What about the ICD? The mode of death in cardiac amyloidosis, unfortunately, is related to electromechanical dissociation. And a lot of the authorities will not recommend putting ICD as a primary prevention. And only they will use it as a secondary if somebody is proven to have death related to ventricular arrhythmia that, would benefit. But usually it's not recommended to put ICD in those patients because it will not help prevent the death as a primary prevention, because the mode of death, or the commonest mode of death, is electromechanical dissociation, unfortunately, which will not be treated with the ICD. I think this is my last slide. Thank you. And I hope that everything was clear, especially the sound.
Thank you very much, Dr. Kharabsha. Very nice and elegant as usual. Few questions. One of the questions raised here, any role of the standard medical therapy like ACE inhibitors, ARNIs, ARBs,
you very much. Yeah, we talked about, you know, that first, those drugs to treat only just cardiac amyloidosis, you know, those patients, initially, they will have, let's say, a preserved ejection fraction. And we know ejection fraction, let's say 50 or more. Later on, the ejection fraction goes down usually to the mid-range, as you know. Most of those patients, you will see EF between 40 to 50. These are the area, as you know, we don't have a lot of data. First, if you talk about data, whether ASARB, ARNI, we don't have a lot of data on it. But also thinking about pathophysiology, that the main pathophysiology here is the stiffness of the ventricle. Both actually, the passive and the, you know, passive stiffness and the active relaxation, and the very small cavity, very limited filling. So that also makes the effect of these drugs likely less. And the third thing which I want to explain is, as I mentioned, they are very intolerant. Their blood pressure is usually low. And we end up stopping almost all these medications, unfortunately, with the advancement of the disease. So we don't have a lot of evidence on that, number one. Number two, they're usually very intolerant. And I don't think physiologically, as I mentioned, they're classified in the mid-range or preserved. We don't have a lot of data on that. And we know even the ARN, you know, but of course that did not include amyloidosis. Still, that did not show a lot of effect.
It's actually one of the red herrings, as you mentioned, patients who are known hypertensive, taking these drugs for a while and then suddenly become intolerant and hypotensive.
Absolutely.
And that's how we think of it and we investigate for it.
Absolutely.
Excellent. A second question is, it's obviously a rare disease. First, I think they're asking how rare is it, the epidemiology, and is that a challenge in making us clinicians actually think of it when we investigate these patients?
Absolutely. It was perceived as a rare disease in the past because the diagnosis, Walid, and because of the therapy. I put both, because we used to say, so what? I have this elderly woman who comes to me with recurrent heart failure. Let's say, as you say, the echoes showing LVH. Blood pressure is on the lower side. You have a lot of sort of constellation. Maybe she's having a carpal tunnel. I'm sure Baha covered all of that. Then we say, okay, now I want to send her for cardiac biopsy, endomyocardial biopsy, you know. First, the risk, you know, you're a heart failure transplant. If I tell you, it's like, oh, you know, come on, Slim, I'm 70 years old. You want me to perforate her and she will die. I will sort of expedite the demise of this lady. So, okay, I diagnosed amyloidosis. What's next? There was no therapy. Now, with the ease of diagnosis, we're seeing that more frequently. Now, when we look at certain groups, let's say heart failure with preserved ejection fraction, we're finding around 13% of those patients, they have amyloidosis. When we look, the highest, I think, percent we found in patients with aortic stenosis coming for TAVI, elderly, around 16, they're saying around 16, 17% have. So yes, now it's been more recognized and more diagnosed. And we're interested in it because we have therapy too. I think if we didn't have therapy, we'll go back again to this square one. Why should I diagnose all these patients? And there's no specific therapy. It's all just supportive therapy. Does that, I hope that helps.
That's very nice. It actually reminds me of a recent patient I saw, 90 years old, whose echo was classic amyloidosis and the picture was typical, but unfortunately they did not have healthcare coverage. They were non-Saudis and they did not have access to further treatment and management. And I counseled the family and told them, this is most probably this. Even if we diagnose it, I don't know what can you do next. Would you have done anything different?
No, definitely. I agree with you 100%. I think that's a very wise decision. And even if they're a Saudi, 90 years old, we're thinking now actually to put even a guideline who to give the drug. To remember, the drug is still very expensive, you know, in this era. So we have to really also select which patient who will benefit from it or will, you know, or to, I mean, now in the corona, of course, we have to put corona and everything. As you see in Italy, they said anybody above 65 will not put him on the ventilator. So we're not that cruel, but I think we should think about a priority. Yes, I agree with you 100%.
Yes. One question here about any role of antiplatelet therapy, and I would add, or anticoagulation in these.
Okay. Antiplatelet, as you know, no. we don't have any data on antiplatelet. But as I mentioned earlier, we have a very low threshold for starting anticoagulation because of the infiltration of the atrium. It causes electromechanical dissociation. So the patient will be in sinus rhythm, but yet he might embolize. If the patient has any signs of embolization, Waleed, well, I think we should start anticoagulation without delay, systemic anticoagulation. Now, if the patient develops atrial fibrillation, as I mentioned, don't calculate Chad's VASC score, start anticoagulation. So yes, we have a very low threshold, but not everybody starts anticoagulation prior to, or let's say somebody just recently diagnosed, never had embolization, he's in sinus rhythm, no, we don't have data on that. But if the patient had any signs, strokes, TIA, peripheral embolization, then while he's in sinus rhythm, just anticoagulate.
A question here about the diagnosis. I know your coverage was about the therapy, but mashallah, you can cover it all. What is the standard in diagnosing cardiac amyloidosis? Cardiac biopsy or nuclear? And actually, it's a bit wider than that, but you can probably take it from there.
Yes, I think now when we say about cardiac amyloidosis, remember this is a range of diseases. We're talking about AL amyloidosis, which is common. And then we talk about the ATTR amyloidosis, which as a cardiologist, we're interested in. So to diagnose it or to confirm it, definitely you need to go through the diagnostic criteria. Patient comes, you're suspecting it. First thing, by symptoms, you do echo, then plus minus MRI, let's say, you confirm that there is a highly suggestive of amyloidosis. Now, until now, you're saying amyloidosis. You cannot say this is by echo or MRI or by the clinical, this is AL versus ATTR. Remember, we said these are two diseases. Treatment is completely different. One goes to the hematology, one comes to us as a cardiology. Now, next thing, now in the new algorithm, of course, you will do the, what we call it, the serum and urine protein immunofixation for everybody. You have to do that for everybody. And then if that's positive, then you know that this is likely if you have the MRI and the echo suggestive with the symptoms and you have a positive, let's say, serum or urine immunofixation, then that's likely AL amyloidosis. And then you can get also even a biopsy, abdominal fat biopsy, but to confirm that. Now, if that's negative, then you can do now, we don't go to the endomyocardial biopsy or the tissue biopsy first. We do the bone scintigraphy, which Dr. Hussam talked about. It has a very high specificity. If you get, the significantly grade 2 or 3, then that's highly, with a negative immunofixation, then that's highly likely this is ATTR amyloidosis without even biopsy. Now, if you get grade 1, which is mild, that sometimes goes with the AL amyloidosis, or you have to repeat the scan sometimes after few months, and you can confirm it. So you have to go through the algorithm to diagnose it, but you have to definitely always do the urine and protein serum electrophysiology. Scintigraphy comes very high on before even you consider the biopsy. The biopsy now is really the last. And they're saying negative biopsy does not rule out if you have a high clinical suspicion, because it depends upon the site where you take the biopsy.
Someone is asking here about any association between cardiac amyloidosis and amyloid angiopathy in the brain causing bleeding. Have you seen any? I know amyloidosis can affect several systems, but I don't know if they...
Exactly. Remember, Alzheimer's disease is also, they find these amyloid deposits in the brain by MRI. But no, I have not seen any cases. I don't think there is really a direct link, but it's all, it's called amyloid angiopathy. But I think it's different than the systemic amyloidosis or the ATTR amyloidosis, which we talk about.
Yes. Personally, have you used tafamidis, and is it available freely in your hospital?
Yes, I've used tafamidis. We've used it now in 2 cases at our hospital. It's not freely available. We have to get it through the Ministry of Health. So we have coordination with the Ministry of Health because the hospital doesn't have it on formulary yet. But we're applying to have it on formulary, and we're putting a guideline, as I mentioned to you, to which patient to give it for sure. But yes, we've used it in 2 cases by far, and we get it through the Ministry of Health. We send a referral, a report dictated, and they have some supplies. It's not freely, but they have supplies. If you have a good indication, they will dispense it.
Excellent. Here, one person asked 2 questions. Let's start with one first. Does the amyloid affect both ventricles, or does it predominantly affect one of them?
It affects both ventricles, but predominantly the symptoms are usually related to the left ventricle. But both, you will see thickness and even the RV wall, definitely.
Yeah. Clinical indicators of cardiac amyloidosis where you should initiate investigation. What are the clinical indicators?
Yeah, this is actually, it's a whole lecture.
Yeah,
I know Baha gave that lecture. But exactly, as you mentioned, usually you look for that in different groups of patients. As I mentioned, heart failure, preserved ejection fraction patients with a low gradient, low flow aortic stenosis, patients who are coming with recurrent heart failure, unexplained. Of course, subgroup of patients, remember the neuropathy, bilateral carpal tunnel always raises the suspicion, usually precedes those patients by the symptoms or cardiac symptoms by almost 7 to 10 years. So there is different groups, but the groups which you should look for, patients with the neuropathy who comes with neuropathy, heart failure, those are the ones who to look for. But there is a group, patients on dialysis, renal failure patients, they have also a certain percent. Now, the patients, the presentation is usually heart failure. Usually, predominantly, you see both, right and left, but you see a lot of right-sided heart failure. And the echo usually gives you the clue. The ECG, the echo gives you some clue. So a patient's coming with heart failure, you do ECG, let's say, you see normal or low voltage. You do echo, you have LVH. So what we call it, the voltage mass discordance. So this is one of the initial clues. Conduction abnormality is very common on the ECG. Pseudo-infarction, you see Q waves with no coronary disease. These are clues on the ECG. The echo, of course, has many, many clues. I know Dania bored you with all of this if she gave the lecture. You start from the pericardium, you see almost always small pericardial effusion. You look at the atria, as I mentioned, you see the atria, what we call it, the electromechanical dissociation. You look at the end, usually, especially with advanced disease, they don't contract, they're just dilated, and there you look at the frame systole, diastole, they don't contract. You look at the interatrial septum, very thickened. This is one of the valves, all the valves become thickened. Of course, LVH on both the RV and the RVH, LVH, but predominantly LVH with all the diastolic. And typically, when you look at the longitudinal strain, you see that what we call a cherry on the top. The base of the heart is affected much worse than the apex. The apex is spared, which is contrast to other diseases like hypertension and aortic stenosis. We call it cherry on the top. That's one of the classic symptoms. So these are the clues from the history. Then you look at the ECG, echo. Then you proceed with further, as I mentioned, MRI and others. The MRI also has a whole characteristic. Maybe Dr. Hussam can talk about the imaging part.
Obviously, the people asking here want to give lectures and lectures. This is a question which I hope it's going to be a lecture by itself. If you're able to summarize in a few points, and it would be our last question, how would you differentiate between amyloid and Fabry's disease?
Well, that's a very difficult question. That's a very difficult question. But I mean, the patient, from the symptoms, there is some clues, but the main issue, patient comes, with heart failure, let's say, and you look at the echo, there is signs. Now the Fabry's on echo, I think I'm not an echo guy, I really cannot give you all the clues on it. But eventually, when you reach the degree eventually it's going to be the bone scintigraphy. Second is, the immunofixation, then biopsy. That will eventually differentiate. The enzyme assay, of course, for Fabry's disease will be the differentiation, not only solely on let's say, the symptoms or the echo finding. They are all suggestive, but eventually it has to be really, the scintigraphy should not be positive in patients with Fabry's disease. And it's very, sort of simple test, non-invasive, we do it now before even you do the MRI.
I think the age is also totally different between those who present with this and that. And the imaging can differentiate. Someone said here GLS can differentiate also between amyloid and... As I told
you, many things. These are suggestive, but eventually you have to confirm it if you want to treat.
Exactly. Well, I think we came to an end. It was a very fruitful and active discussion, and it would keep on going. But for the sake of time, I would like to thank both of our speakers today, Sam and Dr. Sorry. Yeah. And of course, my co-chair, Dr. Abir, for taking care of it. And we do thank Pfizer for sponsoring such an event. كل عام وانتم بخير. We hope to see you in future events, inshallah. Thank you very much.
Okay, thank you, Mr. Chairman. Thank you for everybody, and wish you a happy Ramadan. Thank you.
Okay, thank you, Walid. Thank you, Abir. Wonderful seeing you.
Thank you.
Okay, see you. Good night.